Hi, thanks, Elaine. And to those of you I haven't met, I'm Hannah Mitchell, working with the MOT clinic in ID. I'm also speaking to you here from Vancouver, from the traditional ancestral and unceded territory of the Coast Salish people, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I do, along with my clinical work here at the Vaccine Evaluation Center. We receive funding from a variety of sources, including non-for-profit, government, and industry sponsors. So I have been a co-investigator on a couple of trials funded by the industry, and these funds get paid to us for operational costs, and we as physicians do not receive any personal payments, but hopefully some insights into how trials are run and vaccines evaluated. I wanted to talk briefly about vaccines after transplant in general, and then talk about a few of them in a bit more detail. Vaccines after transplant are generally very similar to the routine, the usual vaccines that would be recommended if your child or teen did not have a transplant. For some vaccines, there would be extra doses or slightly different schedules. And that really depends on your child's age at the time of transplant and vaccines they received before transplant. So we find that children who received transplant quite young usually have more modifications and catching up to do. People who were transplanted in their teenage years, close to being adults, have already received most of their vaccines and usually just require a couple of additional ones. Most vaccines, fortunately, are publicly funded. After transplant, we recommend that you wait about 6 months or until you're on your baseline, regular immune suppression for better immune response. And similarly, if your child has treatment for rejection, we would suggest waiting for 1 to 6 months for better immune response, depending on what medication you received for rejection. Non-live vaccines, so these are vaccines that do not contain a live bacteria or a virus, but usually a small particle to help induce vaccine response, are listed here, starting with kind of tetanus-containing vaccines, pneumococcal vaccines preventing pneumonia and sometimes more serious complications, and we'll have new vaccines coming to BC soon, not quite yet, but in the next year or two. Meningococcal vaccine that prevents from meningitis, which is a brain infection from a couple of common strains, A, C, Y, and W. And in addition to that, there is a meningococcal B vaccine that's not included in the above, but is currently not publicly funded. HPV vaccine, which I'll talk about a bit more in just a moment. Hepatitis A, which is a kind of a foodborne infection of the liver. Again, not publicly funded for everyone. Hepatitis B, liver infection, and then, of course, COVID and flu. And I wanted to talk for a couple of minutes about HPV because kind of through my work in clinic, I've been noticing that a lot of our transplant patients are not fully immunized against HPV. And I sort of have my ideas as to why. But just as a brief background, HPV is a very common virus that most young people and adults acquire at some point in their lives through intimate sexual contact. HPV infection oftentimes clears on its own, but sometimes it does not. And when it persists, kind of this virus has a chance to cause abnormalities in the tissue, and it can cause cancers. That's usually genital and anal cancers, or it can cause genital warts. And we're really fortunate that we have a vaccine that provides very good protection from 9 types of this virus that are usually implicated in cancers or warts. And it's more effective if it's given at a young age. And that's for 2 reasons. One is we know from studies that young people in general just develop a better immune response to vaccine compared to older people. And of course, the other idea here is that you get vaccinated before you've been exposed to the virus. And as those of you who have children with transplant know, people with organ transplant in general are just at high risk of not clearing viral infections. So you've probably heard about CMVs and EBVs and whatnot, and this includes HPV. So getting vaccinated really is the best way to get protection. In BC, the vaccine is given in grade 6 to both boys and girls. who all receive 2 doses of vaccine. We know from studies in young people, including children with transplant, that people with transplant usually develop lower amount of antibodies in response to HPV vaccine. So the recommendation is that children and youth with transplant, if they're being vaccinated after transplant, should get 3 doses instead of 2. So what that means is that it's completely okay to get the vaccine as part of your grade 6 vaccines, but you should be coming to clinic or to a pharmacy to get that additional dose to be fully immunized. The other vaccine I wanted to talk about for a moment is COVID, whether we still consider it a pandemic or not. As of last week, out of all the tests being done for COVID, obviously not including at-home tests, about 12% are coming back positive, if that kind of gives you a sense of how much COVID there is around. And that's certainly less than what we saw last year, but there's still definitely, I think, tells me that there is a lot of virus circulating. JN variant is replacing the XBB variant that was the most common variant in the fall. We don't have any data to suggest that JN is any more harmful or faster spreading than XBB, although it's a bit early to say. Risk of becoming very sick and needing to be hospitalized for children and teens remains low. Although I would probably one thing I would say is that in people with transplant and other medical conditions, it's sometimes not so much the COVID itself that gets you in the hospital, but associated problems such as becoming really dehydrated and not being able to keep fluid downs, causing kind of kidney injury, for example. In terms of immunity, we know that so-called hybrid immunity, so that's immunity that you've gotten from vaccines as well as previous infection, lasts longer than vaccine protection alone. We also know from studies in adults and some data we are getting now from children that children with transplant may have lower antibody and cellular immune responses. So antibodies are easier to measure. Cellular immunity is another arm of immunity that we cannot measure as well. But we know that immune responses can be lower, both to vaccine and the infection. And in general, what I've been seeing in studies and through research is that children who are on a single immune suppressant, and that's usually tacrolimus, tend to have more robust immune responses, probably not surprising given it is a single drug, and children who are more than one immune suppressive medication may have a lot lower and sometimes not detectable antibody and or cellular immunity. It's a bit hard to know what that means in real life. Just because we can't measure something in a good way in a lab doesn't necessarily mean that these children are getting more hospital admissions or more a more severe COVID. But part of the idea behind giving the COVID vaccines and giving additional boosters to people with immune compromise, such as children with transplant, is that immune responses might be lower than those in people without transplant. So the way things are looking like is that spring boosters will be recommended for people with transplant, and they'll be rolled out around April here in BC. It will be the exact same vaccine as back in the fall. So that's XBB monovalent vaccine. There's currently no other vaccines developed against the newer variants, but the idea is that it provides a good degree of cross protection against the JN variant, which seems to be most common right now. And booster vaccines are generally recommended 3 to 6 months after previous dose. So if you got your fall vaccine around October, April would be a good time to be vaccinated again. How about live vaccines after transplant? And I was actually really looking forward to talking to you about that topic because I think we have some good and encouraging news about that. So live vaccines are vaccines that contain a weakened bacteria or a virus. Kind of live vaccines that you've probably heard about is rotavirus for babies, and then chickenpox vaccine, and then measles, mumps, rubella vaccine. And old recommendation, which you probably heard when your child had a transplant, was to avoid live vaccines after transplant. And that was not based on big safety concerns or people with transplant having problems with the vaccine, it was based on not having enough information that the vaccine is that a vaccine is safe and efficient after transplant. And the new recommendation now is, and I'll explain a bit more about why in a moment, is that some live vaccines can actually be safely to select children and teens after transplant, which I think is really exciting. So to give an example of the chickenpox vaccine, which is an infection that was very common in children before the vaccine was available, usually causing fever and kind of whole body rash that resolved on its own. But sometimes, especially in older people or in people on immune suppression, causing severe disease, along with posing a longer term risk of shingles. So while children without transplant would get the vaccine at 1 year of age and then at 4 to 6 years old, many children could not be vaccinated pre-transplant or have been vaccinated but lost the immunity because of immune suppression. And we know that we can't rely on other people around us being vaccinated alone for protection. This is information from 2020, so kind of just around the time of COVID. But as you can see, kind of around BC, about between 70 and 80% of 7-year-olds are fully vaccinated against chickenpox. And certainly if you travel, there are many countries in the world, including most of Europe, where I'm originally from, that simply are not vaccinating against chickenpox. So everyone would still be getting the infection. What we started doing at BC Children's Hospital is, after reviewing the evidence and kind of following lead from International Pediatric Transplant Association and other centers, we actually started giving varicella vaccine after transplant now almost 4 years ago, following kind of a clinical guideline and sort of a flow chart that I put a screenshot of to the side there. So we would usually screen children for vaccine eligibility at the time of kind of annual MOT review. So to be eligible, you would of course have to be not immune to varicella, either because you've never been vaccinated before or you have been vaccinated before transplant but lost immunity when we check the antibodies, have to be at least a year after transplant, be on kind of your regular baseline immune suppression, otherwise healthy, and then we would do some additional labs, mainly looking at your white cells in more detail and immunoglobulin levels to see if, based on all that criteria, your immune system is robust enough for you to be able to receive the vaccine safely and also for the vaccine to work. And then for children and teens who meet the criteria, your transplant provider and myself or my colleague in ID would meet with you to provide a bit more information. And if you're interested in being vaccinated, you would be referred to family immunization clinic or public health, if that is what you prefer, and then receive 1 to 2 doses of vaccine given 3 months apart. And then we'll check serology afterwards to see if you are protected. And if you are protected, the nice thing is that you're then considered protected for lifetime and no further vaccines or tests are needed. Side effects I usually tell families about are the common ones. So that's pain, swelling, redness at the injection site. All people with or without transplant can get kind of very limited chickenpox type rash. So it's kind of like getting chickenpox, but from the vaccine instead of from the virus. And that happens not right away, but 2 to 6 weeks after vaccine. And we know that it occurs sort of in 5% or like 2 out of 10 sorry, 5 out of 100 kind of children who are otherwise healthy. And it probably happens more commonly in children with transplant. So if that happens, we would ask you to come to a healthcare facility to get assessed and get the swabs, but you usually wouldn't need antiviral treatment. And since we started vaccinating, we've had just over 20 children in MOT with transplant received the vaccine, including liver, kidney, and heart transplant recipients, kind of ages 3 all the way to 16. Usually 1 or 2 doses. We've offered a 3rd dose if someone did not have immune response after 2. And it was really nice to see that vaccine was very well tolerated. So far, we had 2 children develop kind of mild vaccine-derived rash that I showed you about in the talked about in the previous picture, who came for assessment, but it did not have to be treated. A vast majority of children who got the vaccine after transplant developed antibodies, so they're considered to be protected. And this has been similar to experiences in other Canadian hospitals and abroad. And for participants who are consented to research studies, this information will be put together with information from other pediatric transplant centers, and we'll have data coming soon, sort of give you a bit of a bigger picture just beyond our hospital. But you can certainly, the study is now closed, but you can certainly receive the vaccine without having to participate in a study if you're otherwise eligible. How about measles, which I think has been on a lot of people's minds, hearing about an increase in cases, and currently quite a number of measles cases in Montreal in Canada. So it's another viral illness, again, usually causing fever, cough, runny nose, watery eyes, and a rash. It's very contagious. And unlike for chickenpox, we actually don't have antiviral, so we don't have treatment for it. The measles vaccine is given as part of measles, mumps, rubella vaccine. Again, it's very effective. It is a live attenuated vaccine, and we would usually give it at 1 year and then 4 to 6 years of age. So like with varicella, your child may or may not have been vaccinated before transplant and may or may not be immune. In US, they've just completed kind of a small study where they gave MMR vaccine to children after transplant. I think it was about 200 in total, mainly liver transplant recipients. And like chickenpox, it was well tolerated and provided protection, which is great news. We're not offering it in Canada quite yet. And I'm really hopeful we'll be able to do so in the coming years. And it will be, again, linked with the study, because that basically gives us the opportunity to offer the vaccine, but also collect information so that it can be then done as part of routine care. And last but not least, I just wanted to mention briefly travel vaccines, now that we are all fortunate to be traveling a bit more. So I think it's important to think about, depending on where you're going. So to start with, I would ensure vaccines are up to date, including chickenpox if your child is eligible. And then depending on what you're going, kind of the usual travel vaccines that a travel clinic also will tell you about would be hepatitis A, for places where maybe food safety and hygiene are not guaranteed. Inactivated typhoid, which is another kind of foodborne illness that can cause severe diarrhea and sometimes bacteria in the blood. And then, and probably less commonly, meningitis B, which is meningitis you're not covered against kind of with your usual meningitis vaccines. The infection is more common in some other parts of the world than Canada. And again, because this is a rare infection, it is not publicly funded, but it is available. And then depending on where you're going, I think very important to think about infectious prophylaxis as well. For example, malaria, if going somewhere where there is malaria. So I'll stop here. I would like to share that the BC Transplant developed an amazing handout kind of with the list of vaccines to think about after transplant, and QR codes to where to get more information, so that you don't have to feel you have to memorize or go searching for that information elsewhere. And obviously, we're happy to answer questions in the transplant clinic as well. And finally, we are also always looking at ways to make communication about vaccines better, for not just for parents and family members, but also for children and teenagers who might have their own questions or concerns about vaccines. And if you're interested in telling us more about how you decide about vaccines, or kind of how vaccines fit in all the other big decisions you make in life, from medical care to everything else, we are just opening a study which with interviews for teenagers and parents or other caregivers. There's a small gift card involved. We'll be sending a flyer through the MOT clinic, and there's an email included here as well. We'd love to hear from you. So with that, I'll stop sharing my screen. And I would be happy to answer any questions if I can. And for those of you who arrived late, Annie unfortunately had this family emergency and wasn't able to come here today. But I I'm wondering whether some of you had questions for her, because I know they're just fear of needles and pain management can be very real and important. So I'd be happy to take some of those questions down, and then we'll pass on the replies. Or if there is more interest, we can organize another webinar at another time.
Yeah, thank you, Hannah. So if you do have specific questions about needle fear, vaccine anxiety that you were hoping that you could discuss with Annie and her presentation, please, you could pop them in the chat. We'll also have an email address that you can email us to follow up on, info@bct.phsa.ca. So if you want to just ask your questions in an email, we can also make sure Annie gets them. Our plan is at this point to, once the session is done and we have the recording, if there are any questions that aren't answered during the session, we will prepare the answers for those. Hannah and Annie will provide the answers. We will send out an email with a link to all of the transplant families. And as well, if you have any feedback, please let us know. So the email address is in the chat. If you have any questions now, feel free, if you're comfortable, you can raise your hand and just jump right in, or you can send a question through chat. Or you can send one directly to BC Transplant if you would like to remain anonymous. But while we wait for any questions that might come in, Hannah, I have a question for you about the measles. You mentioned that there's no treatment, but I've been reading articles that say that people who are immune compromised and exposed to measles can get an antibody treatment within, I think it said 6 days after exposure.
Right. Yeah, that's a great question. So I think it's important to make a distinction about kind of getting post-exposure prophylaxis, if you wish. So you can get antibodies, whether that's IVIG or measles-specific immune globulins, to hopefully help you not develop the infections by having some of basically other people's pooled antibodies circulate in your system, assuming that you do not have enough of your own. And that's definitely available, and happy to clarify that in the slides. Once if you've developed the infection, either because you did not get antibodies by IV or because they did not work, then we do not have an antiviral like we do for varicella. So for chickenpox, we can give you acyclovir, oral valacyclovir. We do not have an antiviral against measles.
Okay, so the difference between sort of something that might boost your immune system to help you fight it versus a treatment, which is what you have for chickenpox.
Yeah, exactly. Thanks for clarifying.
Okay, no, that's great. And then another question about measles. Does wearing a mask help at all? I mean, I think we've heard a lot about just how contagious measles is, and that we've all heard things like if you're in a room where someone who has had active measles, your chances of getting it are pretty much close to 100%. So will wearing a mask offer any protection at all?
I'd say limited. It's very contagious. It's aerolized through very small droplets. So usually you would need to do full airborne precautions and wear kind of a certified N95 mask to make sure that nothing comes in. I mean, so there are probably other reasons why we should be wearing masks in places where people have respiratory symptoms, like someone is sneezing, and it can be for any number of reasons, not just measles, but certainly wearing the mask might help to some degree, but I would not consider it protective from measles. And and so Katie and Mike, I think you've had your hand up for a while, so sorry if we did not go in order.
Yeah, I think so are you working with other health authorities on some of the recommendations around the vaccines, particularly because we're in the Yukon, but BC cares for our daughter, but any follow-up vaccine, like any vaccines we would get, particularly where you're recommending 3 doses instead of 2, we would have to do that locally here in the Yukon. And so I guess I just want to make sure that advice is being passed on. So when we go to our doctor for that, it actually is in practice for her.
I see. Yeah. It's usually if there's any kind of question about receiving vaccines, we'd be more than happy to just kind of write out a more formal referral to the public health. And I found that helpful, especially with varicella vaccine. Usually what we do, and if this has not been the case for you, please feed that back to your transplant team. Is at the time of your annual review, with kind of the nurses would usually give you a little checklist saying, we've reviewed your vaccine, sorry, your vaccinations. These are vaccines recommended for you. And then you can either get them in clinic here or kind of locally through your public health. And certainly in the past, if people needed a script or public health needed more information, we would fax over a referral letter and just say this is kind of what you should be getting. So if you, for anyone who needs more individualized advice or support, happy to do that, because I know navigating vaccines after transplant is very different than going to public health, kind of just for your routine 4 to 6 year shots.
Yeah, because I'm not sure, even on the HPV recommendations, I'm not sure whether or not, I'd have to double check what the cycle is, but I don't know that we're actually giving them in schools.
Yeah, we do.
Up here, do we?
Yeah.
Okay, never mind. My wife corrected me, so they are. So
Teamwork.
Yeah.
On that, but I guess it's good that you mentioned that, because the messaging on what the HPV is for has been kind of mixed for us. So it's good that that came up in this. So we'll
just need to advocate for the third.
Okay. Awesome. Thank you.
Yeah, glad to.
But is a third dosage? Is it the same?
It's the same dose. Yeah.
Okay.
And one thing to keep in mind is that for people who got HPV vaccine before transplant, as long as they were younger than 15, the 2 doses were fine. If you had transplant way before you were old enough to get the vaccine, which was the case for a lot of us, then you should be getting 3 doses. And ideally that would mean you could get your school one, say in October, and then the extra one 2 months later, and then your regular school one again, sort of in April. Oftentimes we kind of give the 3rd dose as a catch-up dose when we see that you got 2 vaccines in school like you were told, but it did not flag that you need the extra one.
Okay. And then did you have a question about measles?
Oh, I was curious about the measles vaccine.
Yeah.
Was it? What was it? Oh, so they're not supposed to get it. So our transplant kid's going to be 11 in a couple of months. So we can't give her any more, but we should definitely work on getting the booster for her little sister, right? Or do we need to worry about the live vaccine with her at home and then being close? Or I know that was something that we've been kind of told to be cautious.
Yeah, that's a great question. So because this is a live attenuated virus, the chance of getting something that's contagious in someone who's otherwise well is 0, basically. And even for children who get kind of varicella-like rash, we don't tell them to take any special precautions. So by far the best way to protect children who can't get live vaccines is to get everyone around you vaccinated. Really the only live vaccine for family members where you need to be careful, and I'm not sure if that applies to anyone on the call or not, but to anyone who has little babies who are getting rota vaccines at 2 and 4 months, that virus is shed in the stool and can be transmitted to people with immune compromise. Again, important to give because it's, if you had to pick, it's much better to get vaccine-derived infection than rotavirus infection, but I would be very careful with kind of hygiene and sort of just not letting children to transplant anywhere into the diaper changing area for those couple of months, which is much easier said than done, I would say, kind of from my parent hat.
And I don't know if there's any other questions, but we did have one more. And so you were talking about the anti-rejection drugs. So we're on a combo drugs for that. And so I guess I just was looking for clarity on if there's anything we need to be worried about in terms of getting her tested for like her antibody levels, because she's on MMF and tacrolimus. As the mixture. And you mentioned something about one of the drugs not really being a problem, but another one kind of having a bigger impact. And so I just wanted to get clarity if there's anything we need to worry about in that side of things.
Yeah, and I think all I was trying to get at that is, generally speaking, we see that children and adults who are on combination of immune suppressants oftentimes have lower antibody responses and cellular immune responses. It's oftentimes hard to say whether that actually puts them at higher risk of getting infections, special infections that are rare. And I think part of it is the fact that there's only that much of immunity we can measure like, in the labs, and that there's probably other factors. So it doesn't mean that you have to do anything differently. You certainly shouldn't stop any of the anti-rejection medication, but we think it's part of the explanation why, and you've probably seen that in the studies or in the social media, that immune responses will be different if you're on immune suppressive medication, especially if it's more than one drug.
Thank you.
All right, thanks for those great questions. Does anyone else have any questions that they would like to ask?
Please. I have a couple of things, but I don't know how to put my hand up.
Debbie, you go for it.
Well, there's a couple of things I wanted to ask you about, because I remember when my son was little, he's 25, we were always told, and this is a different virus, which is a herpes virus, which is part of the CMV. Is it what is it called? It's part of the...
Oh, the HSV, like the herpes virus? It's kind of like the HSV, CMV, those viruses?
So we were told that our child, he should never be around anybody that had cold sores, because cold sores are part of the herpes virus, and to be very cautious and don't allow people into the house when he was young. Is that still talked about at all? Is that still considered something that's dangerous for our kids?
So so herpes virus is kind of in the same group as CMV and EBV viruses, and certainly if someone has sores, there's a lot of virus in there, and you can pass it on. And then kind of, your child's risk of developing herpes in large part depends on whether they're already immune or not, and how immune suppressed they are. Kind of like with CMV and EBV, most of us are exposed to herpes at some point in our lives. Kind of the older you are, the higher the chance. So for most children with transplant, if you already have the immunity and you're otherwise on like the regular immune suppression, this is not a problem. Certainly, if you're on more immune suppression or don't have pre-existing immunity, you can get herpes infection, and it can be more serious than just the blister. So yeah, like I think the general recommendation to avoid kind of getting in close contact with someone or touching someone's lesions if they have them still holds. There's obviously some limit to what you can do with people having lesions at home or sometimes in school, and oftentimes we can shed a bit of the virus without even having obvious cold sores. So again, probably like most of you have probably experienced living with transplant, is there's always that navigating, right, the risk and kind of just what makes sense in real life, and that changes a bit on your health otherwise, and just circumstances and what works for you and your family.
I have a couple other questions just quickly. Are you going to share this PowerPoint? Because I would love to have the PowerPoint.
Debbie, will be the link to the recording of the session, which will have the
PowerPoint in it. Okay, because it would be great if you could just email me the PowerPoint, because there's certainly some things that would be great for us to put on our children's our Facebook, not you know what I mean. There's some very good information there. The other thing I wanted to just ask quickly, and I've been going through this with my son, but just for our other parents, is there any recommendations coming from BC Children's Hospital as children transition into the adult world for follow-up of vaccines that are required, as they go into the adult land, because it's certainly something that wasn't there at that time, and we're discovering now with my son that there's a whole bunch of things that he probably needs to be revaccinated for, but they get they drop off the cliff when they come out of the. So is there anything that could be put in place for parents so that they're aware of that as they move into the adult world?
Yeah, great question. So two things. I know my colleagues in different adult transplant clinics and pharmacists have been working on kind of standardizing vaccine recommendations and kind of getting reviews and recommending vaccines in clinic, because that's definitely been identified as a gap. Kind of from our perspective, what we started doing in the last when did I start doing that? In the last 3 years. So that would have probably been after your son has already transitioned to adult care, is just review everyone's vaccines once a year at the time of annual review. And, there could be gaps because people cancel appointments, or, the physician is simply not available, but just give you the vaccine recommendations for now and sort of the coming year. So then as you're going towards adult care, you would hopefully be caught up on the vaccines that you need at that point. I think it's a great suggestion that maybe as part of transition to adult care, we should also have recommendations for, you'll need your tetanus shot again in 5 years, and you're now eligible for Shingrix and such. And we haven't done that yet, but happy to talk to transplant physicians to kind of streamline that.
Well, it just would. I just think it would be really, really useful for families moving over, knowing what's required, because they're immunosuppressed for the rest of their life, and so there's things that expire, like when they're 23, and they expire when they're, depending on when they had them and when they had their transplants and things like that.
Exactly. Yeah.
Okay, great. Thank you very much. Good presentation.
Well, thank you. Very kind of you.
So we are at time now, and so I just want to wrap up the session today. If you do have a question that we missed and you didn't have a chance to ask, or you think of one later, please feel free to send us an email. The email is in the chat. It's info@bct.phsa.ca. Also love to hear any feedback on the session. And in particular, because we didn't have a chance to talk about needle fear and vaccine anxiety, if there's interest in a special session or an additional session on that, please let us know. But I just want to say thank you so much to Dr. Mitchell for, it was all her idea to do this. She wanted to make sure the information could get out. And also to all of you who joined us on what is, well, I know you're, one of you is from the Yukon, right? But today in Vancouver, it's gorgeous and sunny. So we appreciate everyone taking the time out of this beautiful afternoon to join us. As I mentioned, after today's session, we'll be sharing the recording. If there are additional questions that come in, those will all go out through the MOT clinic admin email. So thank you so much, and enjoy the rest of your evening.